Go. Oh. Take 42. Hey class, it's Nicole. I'm going to be giving you guys a brief overview of the case study I was given, and that was is a left CVA to the middle cerebral artery. So I'm just going to go into that for you guys. Excuse me if I look down a lot, I have my PowerPoint on my phone over here. So to start, I just have some statistics that I thought that were important and would really stand out to everybody, since CVAs are happening all the time, and it's a big part of the population that you will see in therapy. So I just want to start with a couple of statistics. In the United States, there are approximately 700,000 cases of strokes each year, making strokes the third leading cause of the U.S. mortality. About 500,000 of these are first-time strokes, and the other 200,000 are recurrent strokes. And on the average, a brain attack occurs every 45 seconds, and every 3.1 minutes, someone dies from a stroke. Switch. Okay. So what is a CVA? A CVA is a cerebrovascular accident, more commonly called a stroke. It is defined as a sudden onset of neurological signs and symptoms that is a result of interruption of blood flow to the brain. There's two ways that this can happen. It can be an ischemic stroke, or it can be from a hemorrhage. Someone who suffers from a CVA, they may experience temporary or permanent impairment, such as language, sensory, motor, cognitive, and perceptual functions. And then like I said, my CVA was based on the middle cerebral artery, the occlusion there that would happen. So these are some of the impairments that can happen from an occlusion in the middle cerebral artery. So this is also the most common type of CVAs. The middle cerebral artery supplies the surface of the cerebral hemispheres and the deep frontal and parietal lobes. The impairments that can happen are contralateral sensory loss and weakness in the upper extremities. It can also happen, there will also be weakness or in the lower extremities, but to a lesser degree. If the stroke is on the left side of the brain, which is what my stroke was, or my case study is, these are the possible things that could happen. The person may experience global aphasia, homonemosis, hemianopia, or a loss of conjunctive eye gaze. Also, motor, sensory, communication, respiratory, bowel, and bladder dysfunction may be impacted as well. So I'm going to go into my patient presentation. So my patient, his name is Norbert. He's a 50-year-old male, left CVA with a right hemiparesis. And he also is suffering from a Broca aphasia due to it happening on the left side of the brain. Subjective information, he's having a difficult time giving subjective information due to the Broca's aphasia. So the patient pointed to his right arm and said, ouch. On a visual analog scale, he pointed to 5, rating the pain as a 5 out of 10. His mental status is alert and oriented ×2. He's confused of the time and situation. He's able to respond to yes and no questions. No difficulty with understanding what I'm saying to him, but he is having a difficult time getting words out due to the Broca's aphasia. So with this inability, he became tearful quite often and he got upset, and yeah. So I'm going to go into his tone in what he's presenting with. So of the upper right extremity, he's in a flexor synergy, which we know what that is. It looks like this. And then his lower right extremity is an extensor tone. So according to the Brunstorm scale, he's on a stage 4 for the upper extremity, which is he is coming out of that tone and out of that synergy for the upper extremity, and then he's mild involuntary extensor tone to the lower extremity and that's a 5, which is coming a little bit more out of the synergy. So he's working his way out of it. For his range of motion test in the evaluation, everything on the left side of the body was within normal limits. On the right side, his shoulder, he developed pain at 115 degrees of flexion. He's lacking 40 degrees of elbow extension due to the flexor synergy, lacking 5 degrees wrist extension for the same reason, and then his fingers are in flexion and pain when trying to extend them. For the right lower extremities, he was able to get his hip into 80 degrees of flexion, 75 degrees of knee flexion, and 5 degrees of dorsiflexion. When testing his strength, his left side was all within normal limits again, but limited due to the limited movements to his right side and the pain, we were unable to test the strength. So the plan of care that the therapist came up with for Norbert is the patient will be in inpatient rehab, so he'll be seeing us for 2 weeks. He will also be going to speech therapy and occupational therapy, so he will be having therapy 3 hours a day, an hour with each discipline. And then he's going to be discharged to an extended care facility to further his treatment. So we are going to work on tone management. So inhibition of the right upper and lower extremities. We're also going to work on pre-functional activities. So we're going to do bed mobility, sitting, transfers, sit to stands, wheelchair mobility, pre-gait, gait, and then try and get to advanced gait. And if we do not, he will continue that at the extended care facility. And they're going to work on community mobility also. We'll be doing this with P&F techniques and facilitation techniques. The physical therapist will reassess the patient 1 week before discharge to make any modifications to the plan of care. The short-term goals for Norbert are to decrease tone in the right upper and right lower extremities, patient be independent with bed mobility, be a min assist with sit to stands. We want to see him stand pivot using the assisted device with min assist, walk 25 feet with a hemi walker, and patient would like to reach these goals while he's in the inpatient rehab. His long-term goals are to be independent with transfers, independent with ADLs, ambulate 100 feet with large base quad cane, and we're going to work on family education, continue rehabilitation at the extended care facility, and then eventually return home with his wife 6 weeks post-stroke. The treatment for Norbert is going to be we're going to work on rolling to the involved and uninvolved side, utilizing P&F diagonals. Also, the treatment that we have set up for Norbert is based on his Brunstorm scale results. So he's coming out of tone. So all of these are to help decrease tone and to get him moving better. So we're also going to work on wheelchair mobility for long distances. Therapeutic exercise can include bridging with a hold, rhythmic initiation, to the right upper extremity into D1 extension to break up that flexor synergy. And the right lower extremity will also do rhythmic initiation and D1 flexion to also break up the synergy of the lower extremity. Patient will get into a quadruped position and do slow reversal holds at the shoulders and the hips to work on controlled mobility. And he will progress to rhythmic stabilization in the quadruped position also. In a seated position, we're going to work on slow reversals, alternating isometrics, and rhythmic stabilization to improve the trunk stability, and then work on controlled mobility. And then to strengthen his quadriceps and work on standing and pre-gait activities, we're going to do sit to stands with agonist reversals. We're going to start from a higher surface. Work to a lower surface to make this more challenging for the patient as he gets stronger. Transfers will begin for us with a stand pivot, not utilizing any AD. And then once he's able to get that down, we're going to progress to a stand pivot utilizing the assistive device. And lastly, transferring with assistive device by himself. Progression of treatment. So this mostly will be done while he's at the extended care facility, unless Norbert progresses quickly here with us. But treatment will progress according to the Brunstrom scale. So as he continues to come out of those synergies on his right side, his therapy will progress to help him get better. So stage 5, he's in stage 4 for the upper extremity and stage 5 for the lower extremity. So when he gets to stage 5 for the upper extremity, he'll be working on more complex movements outside of the synergy pattern. So you will progress from just doing inhibition techniques to that, to working on actually utilizing his arm more. Stage 6 will focus on coordination, balance, normal timing of movements. So he will do a lot of standing balance techniques and utilizing PNF techniques also to help him get stronger. And then stage 7 is return to function, focus on perfecting fine motor skills. And then the outcome for the patient's ultimate goal is to return home by 6 weeks post-stroke with his wife. With utilizing physical, occupational, and speech therapy, patient is thought to improve in all areas to reach the best possible outcome. It's important to know that this is just what I chose for my patient. These impairments may not happen to this type of stroke. There are many things that could happen, so it's always important to take a stroke patient at face value and handle their treatment according to that patient, because things can always happen and there may be different impairments. So that's my patient case, and I hope you guys enjoyed it, and see you tomorrow.